Good morning, and thank you, Cardi, for coming here for having me here. So, today's question, just to summarize, I don't have any conflict of interest. For case summary, we have a 45-year-old male who has, as per case summary, worsening heart failure, past history of AKI, secondary to UTI, which is now improved. He has CKD, creatinine 1.9, GFR 31, potassium stable, and he has diabetic nephropathy, microalbuminuria is there. Heart rate is 100, blood pressure 110/70. Ejection fraction 25 with dilated LV, where the LV remodeling is there in terms of severe MR and grade 3 diastolic dysfunction. NT-pro-BNP 2600 is there. So, with this case summary, what are the things we make out? That there are issues. We are dealing with a patient who has severe LV dysfunction with LV remodeling. He has worsening heart failure. There's grossly suboptimal GDMT, and the patient has baseline CKD stage 3B. Because, the challenges are there. What we need to do in this patient is medical optimization, starting GDMP and optimizing the therapy, removal of unnecessary medicines which can complicate optimization and starting of the GDMP, and the challenges with RNI. Because my topic is confined with RNI, whether we can start RNI and what are the challenges. Challenges in RNI in this patient will remain three: hypertension. If the blood pressure is already 100, 110, will it go further down? And if down, what will happen to my patient? Hyperkalemia and AKI. So you see, RD, we know that it is severely underused, and despite having this much evidence, still the penetration in the required population is less than 4%. Now touching hypertension, what happens when you start RD in patients, those who are having blood pressure less than 110? Even those patients having blood pressure less than 110, there is significant 12% reduction in CV hospitalization and hospitalization in these patients. So do not go by blood pressure reading numbers alone. These patients with low ejection fraction, they have lower blood pressure, and RNA still has benefit in these patients. And the patients who are having hypertension, is still there's significant reduction in death and heart failure hospitalization is there, even though blood pressure is less than 110. So the question in your mind regarding if the BP goes further down, what will happen to my patient? All the benefits of hardening are secured. Coming to hyperkalemia, which was nowadays has been largely mitigated, but when RD came, it was always in our mind what will happen to hyperkalemia, particularly if the patient is having CKD. Why hyperkalemia is so important? Because cardiac patient, low ejection fraction, they are already at the risk of arrhythmias. If you top it with some sort of already potassium homogeneous metabolism abnormality, hyperkalemia or hypokalemia, the risk of cardiac arrhythmias goes significantly high. And particularly the patient who is having CKD and MRI is also being given, the risk of hyperkalemia goes further high. But what is the role of, if you see, compared to the previous medicine, which are the patients who are having high risk of hyperkalemia? If your GFR is low, like the patients who are having CKD, the risk of hyperkalemia naturally will be on the high side. And if you are having worsening renal failure, again, the risk of hyperkalemia would be high. In all the patients who are hospitalized, almost 9% they have hyperkalemia. 10% of the patients who are on ACE inhibitor during 1 year, you find your challenging hyperkalemia is there. Or almost 10 to 40% patients on ACE inhibitor RNI, they develop hyperkalemia during the course of treatment. But what is the impact of RNI compared to previous established therapy, with the Telmisartan or here in enalapril? The serious level of hyperkalemia is significantly lower compared to enalapril with RNI. So again, this data also shows that by starting RNI, you should not be unnecessarily fearful regarding the hyperkalemia risk. Compared to renal impairment also. Now, the renal impairment is always, we have seen the part and parcel of the heart failure. Heart failure, the renal impairment happens because of many reasons. Sometimes the kidney is responsible, sometimes heart is responsible. If you overtreat these patients, if you overdiabetize this patient, again the renal function goes down. If you undertreat these patients, the LV function goes down, cardiac output goes down, again the CCF cycle, the vicious cycle sets in. So this worsening of renal failure is always part of this thing. But the cause of worsening renal failure during decompensation episode should be clearly seen. As I mentioned, what is the volume status, which is largely responsible? Is there any infection? Was there UTI? Was the patient has taken NSAID concomitant medication, which could have been avoided or not? So, what happens in patients with RD versus ACE inhibitor? There is lower incidence of elevated serum creatinine. There is significantly lower reports of creatinine going more than 2.5 compared to enalapril. And these are the head-to-head study compared to established molecule. Like before RD was using losartan, enalapril, valsartan, and all these things. Compared to them, the risk of hyperkalemia is on the lower side. In fact, with RD, because of virtue of improvement of renal active function, because cardiac output goes up. Even the GFR goes up. Here you can see, and it does not need any dose reduction as far as the GFR is more than 30. GFR more than 30, you can start the dose as normal as you can and just monitor in these patients. Thank you so much.
Our next speaker, Dr. Prajapati, who's going to talk on two important topics, like is it safe to initiate MRE together with R9, and does choosing eplerenone over spironolactone in this case scenario have scientific evidence? Over to Dr. Prajapati.
Thank you, and thanks, Dr. Kamal, for a wonderful conference today. So I'm going to discuss in that case scenario. So we know the important four pillars for heart failure with reduced ejection fraction, and of course nowadays our MRI is making entry into the preserve or the mid-range ejection fraction, because the limited data is available for the mid-range and normal ejection fraction or preserve ejection fraction. So initial studies with normal ejection fraction were failed, but the Bendopnea seems to be a little promising for the patient with a preserved ejection fraction. And of course, these are the SGLT, among the SGLT2 inhibitor MRAs. The MRAs is a proven therapy among the four pillars. And one advantage of MRA is relatively hemodynamically neutral molecule, doesn't affect much. So we can start as an important pillar within 1 month, MRAs to be given. And particularly this case, when the eGFR, most of the cases when we start with the early and MRA, combined together, we are going for the potassium level, and of course we have to see the renal function. So 30 to 31 eGFR, so we can start with the eplerenone 25 milligram per day and spironolactone 25 milligram every other day, and we need to increase later on, and we should get the, depend on that, how much the patient eGFR improves, and then we have to go ahead. And potassium, 4 to 5.4, no adjustment dose is required. And if it is more than 6, then we have to stop the MRA. And 5.5 to 5.9, we have to be very careful and we have to monitor the potassium level. So that is a crucial thing. And nowadays, the potassium in our current guideline, nowadays one molecule from the extra will be available. Even patient have got a high potassium level, we can give potassium binder. Up to the data up to 11 months, that study is available. So we can give that potassium binder, and we should give the benefit of MRS and only together as an important pillar. So we have to see the minimum eGFR 30 and less than 30 if patient already want, then we have to think, and less than 20 we have to stop the MRA, and that is a very important thing. And among the MRA which to be given, so data available with the reduced ejection fraction is eplerenone and spironolactone. There is no head-to-head comparison between these two molecules, because most of the studies they are the placebo versus MRS, and the selectivity of eplerenone is bad. Of course, it's better molecule, and no, it's a selective molecule, so no, it doesn't cause a gynecomastia. It is less potent, but of course the selectivity is higher. So eplerenone we need to give little higher dose. So spironolactone 25 to 50 milligram maximum dose, while the eplerenone 50 to 100 milligram is a maximum dose. These are the various data with the MR which is available, and these are the studies. And this is HF. Another is the infectious trial. Even with the post-MI, ejection fraction less than 40, we should start it early. So according to UACR guideline, MR is recommended patient with LV dysfunction and heart failure after STEMI. Eplerenone 25 to 50 has been shown to be effective in reducing mortality for heart failure patient when initially early post-MI within 2 to 7 days, and it's a class 1 indication, both the US and all the guidelines, and if it is early, it's always better with the MRA. So these are the comparative data, and there is a date from NT-pro has been reduced with this molecule based on emphasis and all. Class 3, 4, this patient is class 3 and 4, so we can give eplerenone. We can start with the 25 milligram, and then we increase up to 50 milligram, and potassium is 4.1. So this is the post-MI early dysfunction, the study with FSS has shown that 15% risk reduction is there, so it is to be given. So, this guideline mentioned, as I have mentioned, in patients with reduced ejection fraction, it's a class 1 indication, NYHA class 2 to 4, and spironolactone is recommended, but the apelleron has got advantage in particular male patients that gynecomastia incidence is very minimal. And if the eGFR is more than 30 and potassium is less than 5 or to 5.5, we can start, but we have to monitor the potassium level. And 2023 ESC, they says also can be considered for mid-range ejection fraction, also like pedrinone and all. And if we give early, we should not stop it. So better we should give many bit of MRA. Why? Because there is if we don't give, there is a 24 to 35% realistic risk of all-cause mortality, and more than 42% it will be so hard to hospitalization. So this is a great benefit we can achieve. So we have to give it, and we have to maintain the MRA continuity, and we have to correct the cause of the hyperkalemia, like diet and everything. So we should give the benefit of this molecule in this case. So timing, as I have told, MRA early less than 3 days, and we can not give the late, and of course start with the more low dose, and then we increase. We have to monitor the potassium and creating a 1, 4, 8 and 12 weeks, and then every 4 months. And diabetic patient also, we have to monitor the potassium level, and that's why we can continue this molecule. Only thing we have to stop at more than 6, we have to stop. 5.5, we have to find out the cause for the potassium, high potassium level, and we should treat accordingly. And probably the potassium binder will be available in the future, so we can continue the benefit of MRA and AMI both. Thank you so much.
Thank you, Dr. Prajapati. And now we have Dr. Tejas Patel to talk on 3 important topics like given the history of AKI and UTI and partial. What challenge with SGLT2 1 instead of DPP4? Moreover, will SGLT2 have influence on CKD? And do I have to use specific SGLT2 or slots for the mortality as well? Dr. Patel, please.
Once again, big congratulations to Kamal Bhai and team, and thanks for having me here. Thanks to audience also for joining today for this excellent academic fiesta. So I'll directly go to the address the important questions for the SGLT2 inhibitor and its role in the heart failure with reduced ejection fraction. So is there any specific SGLT2 inhibitor for this therapy, or is a class effect for the mortality for all? So we know that SGLT2 inhibitor basically addresses the core of the pathophysiology of the heart failure, and in multiple ways. Either it is a preload reduction, either it is a myocardial hypertrophy or remodeling issues, or either it is an afterload reduction. It addresses all the issues, and that's why it is one of the main pillars for the heart failure with reduced ejection fraction therapy. And the initial studies, MR outcome, where empagliflozin in a subgroup, it was found that this molecule, this class of molecules specifically, beneficial in the patients with the heart failure, and it significantly reduces the heart failure hospitalization at that time. And subsequently, we all know that now this class of molecule is associated with reduction in the total cardiovascular death as well as hospitalization because of the heart failure, regardless of the diabetes. And that is a landmark trial that was DAPA-HF and Emperor reduced, which has shown the benefit of this class of molecule in this particular therapy. As per the statistically robust meta-analysis, again the risk of CV death and HHF reduced irrespective of even ARNI use. So it's one of the main pillars irrespective of the other pillars when we use for the heart failure. And now it is useful. It has been found to be useful for all spectrum of the heart failure therapy, and that has been statistically significant as well. Now there is no head-to-head comparison between these two molecules as such. The two landmark trial, Emperor reduced and DAPA-HF, if we see that the study population in the Emperor reduced, the heart failure patients were higher risk. So the higher risk events in the placebo was found in the Emperor reduced, which was lower in the DAPA-HF. So in a way, we can conclude that the patients in the Emperor reduced are at higher risk for the more sicker heart failure patients. And again, in those studies, the patients were treated more with the device therapy as well. And in that situation also, the SGLT2 inhibitor, specifically empagliflozin, has given the mortality benefit in those patients. And this is the number needed to treat for that, and the absolute risk reduction by all these molecules, and the main pillar of the therapy for the heart failure. Now, coming to the second question, whether kidney benefit beyond the heart failure is there or not. Specifically in these patients, when patient having AKI, neurologic rate is very high, whether we should initiate SGLT2 inhibitor or not, that is very, very important. So far, Emperor Reduce and the DAPA HF were not designed to evaluate the effect of subgroups of the CKD outcomes of that particular molecule. But the recent meta-analysis, which was published in 2020 in Lancet, which has found that the kidney outcomes are more favorable with the SGLT2 inhibitor. What they have found that the 50% or higher decline in the eGFR, or patient may progress to the end-stage renal disease, which requires transplantation or the permanent dialysis, which was lower with the SGLT2 inhibitor group in comparison to the placebo. And that's how it has been beneficial to reduce the renal disease progression, specifically in those subset of the patients, and specifically in the heart failure patients. So we can safely give this type of molecule when the patient having altered RFT in the heart failure. And the last patient, which is very, very important and relevant, genitourinary infection, which has been found in almost all trials, but there was not much statistical difference of this particular complications in comparison to the control arm. The most important thing is that there is no increased risk of UTI with the SGLT2 inhibitor in comparison to the placebo, but genital mycotic infections are 3 times higher with the SGLT2 inhibitor, specifically in the female patients. So this thing is very, very important. Forehead gangrene or other rare complications, serious complications are very, very rare. If we see the cardiovascular benefit of this molecule, these side effects are very, very negligible. So what is the important thing is that we need to assess the risk for the UTI or the genitourinary infection, specifically if the local problem is that we need to assess if the patient is having infection while giving this molecule. Another important thing is universal counseling and the hygienic. Hygienic part is very, very important. So we need to minimize the interruption of this molecule for the sake of the cardiovascular benefit, and the guidelines says the patient having mild to moderate and stable severe infection, don't stop SGLT2 inhibitor and continue with the same molecule in spite of the infection. We should not stop that. So the take-home message, last 2 slides, it is class 1 recommendation and is the main pillar for the heart failure therapy right now, SGLT2 inhibitor as per the EAC guideline, and the focus update in 2023 EAC, which has shown that it should be started pre-discharge when the patient admits for the acute heart failure in the hospital. Thank you.
Thank you, Dr. Tejas. And now it's time for the man behind the show, Dr. Kamal Sharma, to come on the dance and talk about sodium zirconium. And I think he deserves a huge round of applause for conducting this very good session. Dr. Kamal Sharma, please.
So basically, when you treat a patient with kidney disease, with all these therapies, we are always worried about one problem, hyperkalemia. Until now, in India, we did not have a therapy that can address this. And now we have a therapy, and that's why I'm talking about this therapy now. So how do you maintain optimal RAS in the patient? We all know, you ask any nephrologist in any conference, what is the best drug to prevent kidney damage? They will say ACE inhibitor ARB. And when you see their prescription, 50% will stop it when you've written it. The problem, hyperkalemia. So what is the new therapy that's coming in? Beta blocker MRA, optimized RAS, and SGLT2 we have given. And I think this slide was already shown by Jayesh Bhai. This is problem is hyperkalemia. And what is the risk once you get a hyperkalemia? Irrespective of arrhythmia caused by hyperkalemia, the potassium-related mortality, from non-arrhythmogenic risks, including death in myocardial infarction, is 12 times higher if potassium is 5.5 plus. Also, 6-month hospitalization risk is 2.5 times higher if patient has hyperkalemia. This is for compared patients which are matched without hyperkalemia with CKD. So what is the choice of therapy? This is the drug, sodium zirconium cyclophyllate, which is highly selective potassium binder. We already have what we all know traditionally, and let me name it from a competitive company, the K-bind sachet, which everybody writes. What's the problem with it? its onset of action is not before at least 2 to 3 days. Here is a binder which acts as soon as you have given the therapy. Its relative diameter of major cations is similar because of the diameters of potassium and NH4. They fit best into the pores of this molecule, which is the size of 3 angstroms. And based on the in vitro data, this begins working in small intestine by capturing intestinal potassium immediately the moment you consume this therapy. It binds the potassium throughout the GI tract, including the small intestine as well as large intestine, and it exchanges it with the hydrogen and sodium. What it does, so let's look into the key trials of it. The harmonized trial and its harmonized extension trial were open label study which looked at the therapy beyond a month, including beyond 48 hours and then up to 1 year of maintenance therapy. The placebo group, of course, was a smaller number, and this was patients on 10 grams once a day. What was the potassium level? As you can see, it drops and normalizes at 2.2 hours. Within 2 hours is the median time that the potassium becomes normal. And time, patients who achieve normokalemia, 84% had it at 1 day, 98% had it 2 days. Absolute change, 66% reduction by 24 hours, 88% reduction by 48 hours. And this is within the range that you can achieve quickly as early as possible. So correction phase where you're giving TID, 10 grams of TID versus maintenance dose where you give it 5 grams versus 10 grams OD. And then extension you continue beyond up to a year. The outcomes, as you can see, the mean dose which was achieved were observable at every point during extension, ranging from 1 to 8 millimole reduction, which was statistically significant. Realize A, which was our open label phase 4 real world evidence generation, where they screen symptomatic heart failure patients. Now remember, these are heart failure patients, EF less than 40, no or low dose of MRA. Patient is already on a therapy if required with MRA. There are two groups where they were run for hyperkalemia with eGFR more than 30, and this therapy was initiated and titrated along with MRA. Along with MRA after normokalemia. On normokalemia, high risk of hyperkalemia patients were the other group, and then they were randomized to receive spironolactone with this or without this therapy. What happens when you give it along with it? In the outcome, proportion of patients who maintained normokalemia on spironolactone, which was more than 25 milligrams, of 1 to 6 months of therapy, the risk of hyperkalemia was 4.5 times more, which means if you take with SZC and MRA, your risk of odds of not getting hyperkalemia is 4.5 times. So time to first hyperkalemic event is reduced by 49%, and time to first instant of decrease or discontinuation of spironolactone was reduced by 63%. So what is the dosing? That's the next question. How do you give this therapy? It's starting dose is 10 grams 3 times a day for 2 days, and then it give you with the powder, just like your K-Pint, 45 ml of water, stir it and drink it immediately. Once beyond 48 hours, you just give 10 grams. And then you monitor potassium at 1 week and increment 5 milligram as required. You can actually go down 5 grams and go up to 15. And in special patients on hemodialysis, you can give only on non-dialysis days. Don't give it on the dialysis day because it is dialysis therapy. So it's pretty safe. Practically no side effects. 5.7% reported edema. That's mild to moderate severity. But again, this is probably fluid related, not related to the drug itself. It's hence to summarize, of course, we know SGLT2 is universally recommended. I'm sorry, I'm creeping into the slides of my previous speakers. Hyperkalemia is a problem with ACE, ARB, RB, MRA, the 4 pillars of heart failure. Here you have the choice of supporting the 4 pillars without worrying for the biggest problem or inhibitor of the same. SHC has shown to benefit rapid potassium reduction and maintain the control. Thank you very much.